Calgary. In the interest of time, I'll just let her talk. She's going to speak about what the surgeon has learned about the Carcinoid Syndrome.
Well, thank you very much. I'm actually going to be talking about the lessons we have learned from our multidisciplinary neuroendocrine clinic. And there we go. Take you through this. I would like to thank the organizers for the opportunity to present this. Now, the objectives, first, I have three objectives. I'm going to illustrate the benefit of a multidisciplinary neuroendocrine clinic. I'm going to demonstrate the key role that surgery plays in the palliation and treatment. I have a bias. I am a surgeon, so you're going to see that bias. And I hope through this I'm going to highlight some of the changing manifestations of neuroendocrine tumors that we have observed. Now, to do this, I've divided it into 5 lessons. I've learned more than 5 things, I hope, but I am going to just sort of give you 5 of these. I'm going to illustrate how we came about each of these lessons and review some of the data, some of the world literature, but the data that we have from our clinic. Now, these are the 5 lessons that I wanted to address. Build it, they will come. Lesson number 2, value an alternative perspective. Lesson number 3, build the team around your strengths. Lesson number 4, don't always believe what you read. And lesson number 5, trust your clinical observations and instincts. Now, we've heard that neuroendocrine tumors are a unique and a very diverse group of tumors, and we've been talking a lot about stage 4 disease and the debilitating and sometimes life-threatening conditions that the tumor and the endocrinopathy can put on the patient. And there are a few centers that really have a standardized treatment regimes. And across Canada, we are constantly trying to then develop these centers of excellence across this very large nation. And when we first started this, we noticed that there wasn't a lot of standardized care. So we took on that task. Lesson number 1, build it, they will come. So in 1998, we got together at the University of Calgary and we said we really do need a standardized approach for these orphan tumors. And we put together a multidisciplinary clinic. And we had, at that time, an endocrine surgeon, an endocrinologist, Dr. Rorstad, and we had a medical oncologist, Dr. Sandy Patterson. We all had an interest in this disease, so we decided we would set together this neuroendocrine tumor clinic. We subsequently lost our medical endocrinologist as he retired, but we gained a nuclear medicine physician, Dr. McEwen, and a hepatobiliary surgeon, Dr. Dixon, in 2003. And we then started to, and since 1998, tried to standardize our investigations of these patients and develop treatment algorithms. But very difficult because these are complex diseases. Well, this was our algorithm, and it's been tweaked and developed a little bit as we moved along. But basically, all of our patients undergo biochemical and anatomical and functional imaging, and the keystone to this algorithm is surgical resectability, and we're constantly looking at ways of cytoreducing the tumor burden. And then we were looking at how do we treat the patients, those that had that were asymptomatic versus those with the endocrinopathy. Well, build it, they will come. We were first given 3 clinics a year to see all of the patients. We were told this is a rare tumor, so don't worry about it. We are now have 2 multidisciplinary clinics a month, and we've now gained a medical oncologist who is seeing patients a couple of times a month in his own clinic. We have both the surgeons also seeing these patients, so we have an additional 4 clinics on top of this. So 6 clinics a month for us to see the neuroendocrine tumors. And this isn't surprising, as we've seen this slide before. There's a rise of neuroendocrine tumors in North America, if we looked at the Sears data. Whether this is because we're picking them up better with better imaging, whether it's truly a biological phenomena, I do not know, but it is on the rise. This is no longer an orphan tumor, and we do need to have centers of excellence scattered throughout Canada that are going to see this increasing number of patients. Lesson number 2. Value an alternative perspective. Well, we're very fortunate because we see all of these patients, we see them together as a group, and we all look at patients with neuroendocrine tumors from a different perspective based on our training. And so when a patient is seen by the surgeon, the endocrinologist, the nuclear metaphysician, and the medical oncologist, all looking at the same patient, the same problem, we all bring to the table a slightly different perspective. And we have then been able to tailor design and to treat our patients based on the patient that is sitting in front of us. And this has been a very valuable experience. I've learned so much from my colleagues and from the endocrinologists, the medical oncologists. They've taught me a lot about this disease because they see it in a different perspective than I. I am not qualified to say that this patient requires chemotherapy. I'm not a medical oncologist. Just the same way a medical oncologist is not qualified to say this is a surgically resectable lesion versus not. So all of these individuals have to be involved. And we've heard before then, doesn't just stop there. So we have a dedicated pathologist that reviews all of our pathology, and we have expertise in interventional radiology and anatomical imaging, and we have developed this center, and all of our patients are then seen. And all patients are then looked at from a multimodality therapy when we put this all together. So the difference in perspective has really taught us a lot. And I think it was also alluded to from surgeons. We used to take it very classically. You know, we would operate on a patient and we'd look at our morbidity and our mortality, and we were operating on cancer, so we wanted to know about survival. Well, that's a complete paradigm shift. It is now I'm looking at patients and looking at how best to palliate them. Quality of life, surgical palliation, response to therapy. And that has been taught to me by my medical oncologist and endocrinologist. Lesson number 3, build your team around your strengths. Well, our team was surgical strength. We'll say that because that's how the clinic started off the ground. And so with an endocrine surgeon and a hepatobiliary surgeon, we do all of these cases together, and together we've been able to really push the limits of what we do surgically by having a different surgical perspective at the operating room table in real time. We also have the strength of an endocrinologist that is seeing these patients in the clinic, and so we've been able to advance our understanding of the disease and how we treat these patients as their disease evolves. And with our relationship with the Cross Cancer and nuclear medicine physician, Dr. McEwen, we have used and have always had in our algorithm radionucleotide treatments for our patients. And so building on your strengths, it's a good thing that we happen to pick on surgery as our strength, because if we look at the world literature on neuroendocrine tumors, the best tumor responses, if you look at all of the series, this is Dr. Molden's review of this, showed that it was ablative therapy that has the best tumor response. And so the surgical or ablative strength in which our clinic was the foundation for which it developed probably is why we're making the biggest impact. Now, we can look at something just like small bowel neuroendocrine, because remember, it's very difficult when we talk about neuroendocrine tumors because they're so diverse. But this is, again, the Sears data. And so the 5-year survival of those patients with liver metastases, if we took all comers, is 54%. I want you to remember that number. So surgery has always played a very key and important role in the treatment of neuroendocrine tumors. And of course, this is the surgical section, and I'm standing up here with kindred spirits. So you guys can have your own opinion, but we're going to stick to that one. And it's been in many different ways. Look at it from this perspective. A third of the patients historically with carcinoid tumors used to die of carcinoid heart disease. Well, from this series from the Mayo Clinic, what they found was between 1981 and 1989 that the median survival of a patient with carcinoid heart disease was 1.5 years. So once you had carcinoid heart disease, very little was being done. Somatostatin analogs then came on the market, and so between 89 and 95, all of a sudden these patients were living a lot longer. We were getting their hormonal milieu down with the somatostatin analogs, and this seemed to be one of the things that was prolonging survival. So at the Mayo Clinic, they realized, well, now we should be, and we should consider being much more aggressive with their valvular heart disease, because nobody was touching them before. And so on an aggressive program of going after the valvular heart disease, they then showed even a further improvement in survival. So if we take that and we say, okay, historically, over 50% of patients with small bowel carcinoid were dying of ischemic and small bowel complaints. Maybe if we then intervene with surgery, we can change the natural history of this disease. And so, building on our strengths, it was our surgical strength that we then started to address, and the disease in carcinoid tumors. And I divide that into addressing the mesenteric disease and then the liver disease. And so we had centers like Uppsala that were clearly demonstrating that when you could resect the mesenteric disease, they were getting a better survival than the patients to which they could not resect the mesenteric disease. They were also showing that they were getting an improvement in quality of life in these patients if they went after aggressively this mesenteric disease, regardless of whether they had liver metastases or not. And they concluded that the improvement of the symptoms and the better palliation was a result of a delay in the onset of the ischemic and small bowel obstructive complaints which these patients were historically suffering from and ultimately dying. And that is why there was a prolongation in survival. Well, Rodney had taken you through, and I won't go through the details of his study, which looked at taking out the primary tumor and showing that the median progression-free survival was improved when you went after the primary. And I thought this paper was very provocative because it was talking about maybe tumor propagating factors from the primary that were driving the liver metastases through the portal systemic circulation, or the portal circulation. And it was based on series like this that we were being very aggressive from a surgical point of view and going after the mesenteric disease, despite having metastatic disease elsewhere in the liver or beyond. And reported our series of 58 patients with small bowel carcinoid tumors. Almost half of them were presenting with small bowel obstruction, but the others did not have an obstructive component to it. And we were finding that we could completely resect that mesenteric disease in over 75% of the patients. Only 2 of our patients actually recurred and had a recurrence of their small bowel obstruction, but during this series we had no patients die of small bowel obstruction or ischemic bowel. Build on your strengths. So what about the carcinoid syndrome? Well, again, having the data that has supported, if you can cytoreduce the amount of disease in the liver in a neuroendocrine tumor, you can decrease the endocrinopathy. And if you can decrease the endocrinopathy and have a biochemical response, you will improve symptoms. And if you can improve the symptoms, there is going to be palliation for those patients. And many retrospective series have continued to show us that there's an improvement in survival if we can successfully cytoreduce the liver disease. So once again, with having a hepatobiliary surgeon brought into the fold, we were then able to expand our ability to attack and address these liver lesions. And we reported our series of 58 patients with florid carcinoid syndrome, and we found that we had a subjective improvement in flushing and in diarrhea in 76% of these patients. But we found that that was a little bit higher in the patients in which we were able to do some form of hepatic cytoreduction. All of these patients went through our algorithm and were constantly being assessed and being treated with other modality therapy. But this is just to graphically show the biochemical response of the patients in which we combined some form of hepatic cytoreduction along with our therapy, which included somatostatin analogs, sometimes interferons, sometimes chemotherapy, sometimes MIBG therapy. we had a more significant reduction in their urinary 5-HIA compared to those that were just receiving the multimodality therapy, and the last two bars are all of our patients. So our estimated Kaplan-Meier 5-year survival from our multidisciplinary clinic in Calgary is 74%. And I told you to remember 56%. We think we've really made an impact in survival by being aggressive and treating our patients in a multimodality fashion. Now, we've talked about the various ways in which one can ablate and cytoreduce. So we have the open surgical way of doing it, the resection, radiofrequency ablation, the Swiss cheese, I believe you called it, of multiple resections, and even hepatic artery ligation and ischemia and portal vein ligation. But then there's also other ways of cytoreducing the liver disease, and we're building that expertise, and we have that expertise in Calgary of embolization. Many centers use chemoembolization, some use bland embolization. Our strength was on bland embolization, so we don't have the experience with the chemoembolization, but many centers have shown there is a survival benefit in those patients that show a biochemical response, whether it's bland or with chemotherapy. And the new kid on the block that we hopefully will be hearing more about is the yttrium spheres, and it's showing promise because it is also not only giving us the ischemic component of embolization, but then causing a local radiation effect. And we are in the process of bringing that expertise to our center. Lesson number 4, don't always believe what you read. Do you see a face of a man or a woman by a tree? We talked about Carcinoid Syndrome. This isn't the group that needs to be refreshed as to what the symptomatology of Carcinoid Syndrome is. You know it well, and some of you live it. We know that Carcinoid Syndrome most of the time is mediated by serotonin that has bypassed the liver effect of actually deactivating it. And so the majority of the time, Carcinoid Syndrome is because of liver metastases or a dysfunctional liver that can't keep up with the hormone burden. Rarely we see it dumping directly into the systemic circulation. And the majority of Carcinoid Syndrome patients are those patients that have suffered from a midgut or a small bowel tumor. Well, what we were seeing, not infrequently, because we started seeing a significant number of patients with Carcinoid Syndrome, is that we were seeing patients that had a typical type 1 carcinoid flush, lasting only a few minutes, disappearing, sometimes they're not even commenting that it was bothersome to them. And they were also complaining about intermittent diarrhea and cramps. It wasn't every day, 7 days a week. It may be for 3 or 4 days, and then they'd feel a little bit better, sometimes even constipated, and then this cycle would return. They were being sent to us with normal anatomical imaging, sometimes even sent after a surgeon had been in there and said there was nothing in their liver and only mild elevations in their biochemistry. And people were saying, no liver disease, no Carcinoid Syndrome. But we were seeing this not infrequently. And so it got us looking, and because we were aggressive from a surgical point of view, we were operating a lot on these patients. And what we have found is that 15% of patients with small bowel carcinoids will have this miliary pattern of metastases to their liver. Tiny, tiny microscopic millimeter-sized lesions that are non-palpable. And sometimes if you're not looking for them, and the surgeon isn't aware that these can happen, are being looked over and thought not to occur. And you can see why, when they're this small, none of our anatomical or functional imaging to date is going to pick them up. So we don't believe the report when it says there's no liver metastases. If they have the Carcinoid Syndrome, we believe they have it. And so we started to look at, so we then decided we needed to look at what was our performance characteristic of our investigations. We were doing CTs, MRIs, MIBGs, and octreotide scans on every patient we saw. So just looking at the small bowel carcinoid tumors, we found that the mesenteric disease, pretty good with a combination, but not all of the mesenteric disease was being found. As I told you, 15% of the patients that were having negative imaging on all of the 4 of those modalities we would find metastatic disease. But our imaging was also underestimating the degree of liver disease in up to 35%. The other interesting finding was that peritoneal disease. We only could detect that preoperatively on our imaging in 4 of the patients, but it's found in over a quarter of the patients. And so you need to, for the surgeons in the room, have a strategy for the peritoneal disease because you're going to see it 25% of the time. And we have to start thinking about that and developing strategies for it. We're fortunate that we have a peritoneal stripping program in Calgary, and many of our patients have subsequently undergone that. Finally, the last lesson. Trust your observations and instincts. What we were finding, so we have now been able, I've personally been able to take care of 86 patients with florid carcinoid syndrome. And when you start seeing a volume of patients like this, you start to then see some characteristics. And what we started noticing was that the patients were challenging. They were forgetting instructions. They were coming to the clinic and they would say, yeah, I remember you told me to do something, but I'm not quite sure what it was. And for the surgeons in the room, you can imagine if this was happening on a regular basis, being called to the holding area because they had the patient there, and the patient then told the nurse that was checking them in, I don't have a clue what she's doing today. That sends a lot of problems through the surgical world. And it's not that I didn't spend the time explaining this. The problem was that they weren't remembering it. Only a few admitted to struggling at work. So we felt that we were seeing these, that there really was something going on, and we wondered if there wasn't some sort of neurocognitive effect of patients with carcinoid syndrome. And others have looked at this, wondering if it had something to do with the serotonin or some peptide being produced by this tumor that was affecting the neuroendocrine cells in the brain. And others have said, well, there's a relative tryptophan deficiency in carcinoid syndrome, and we know that tryptophan deficiencies will cause neurocognitive dysfunction. So what we did is we got one of our psychologists from the Tom Baker, Stuart Longman, to help us design a study. And what we've been doing is enrolling patients with carcinoid syndrome and putting them through a self-cognitive test where they self-report their cognitive function, and then putting them through formal neurocognitive testing. And we have the ability to compare that to age, gender, and education-matched norms. We also were worried that some of this neurocognitive dysfunction may be related to just having cancer and just having metastatic disease. So we've been enrolling a comparison group that has adenocarcinoma to the liver that is non-functioning. Their self-assessment questionnaire, what they're basically, we're looking at 5 cognitive domains, and they self-report from 1 being no symptoms to 5 being quite debilitated by it, and this has been previously validated. We've put them through 6 neurocognitive testing, looking at attention and concentration, executive skills, visual perception, language, and then visual and verbal memory. To date, we have 35 patients that have carcinoid syndrome, and we've enrolled 13 of these metastatic adenocarcinoma patients. Those patients are behaving like the norms, and so I'm not going to go into their data, but the carcinoid patients are behaving quite differently. They are reporting globally across all 5 cognitive domains a decrease compared to age, gender, and education-matched norms. They report very poor verbal memory, very poor attention and concentration, and mild visual memory. And yet, on formal neurocognitive testing, their verbal memory and attention and concentration is quite normal. But what we are seeing is a very poor visual memory and perception, and difficulty with initiation. And I just want to illustrate this poor visual memory and perception. This is a picture that they're asked to draw. It sits in front of them. You're asked to draw it out, and they're told that they would also have to then reproduce it within the next hour and a half from memory. So you have to be able to draw it, and then you have to commit it to memory. Our carcinoid patients are drawing pictures like this, and on average, they are missing 2 key elements when the picture is sitting right in front of them. So when on immediate and delayed recall, this picture is disappearing. It certainly explained to me why the pictures of their operation were disappearing when they got to the operating room. So we do believe that there is some cognitive dysfunction. We're looking to see if it correlates with the chromogranin and the urinary 5-HIA. But this has truly changed our communication style in the neuroendocrine clinic. And we really feel that if we're going to truly palliate patients with neuroendocrine tumors, we must take this cognitive dysfunction into consideration. So, I hope that I've been able to meet my 3 objectives. Illustrate the benefits of a multidisciplinary clinic for the centers across Canada. Build it, they will come. And you must value the perspective of all of the team that takes care of these patients, because we all have something to add to it. I hope I've been able to demonstrate the key role that surgery and ablative therapies play. We've built that on our strength, but the surgeons have to be part of that team because that's where the strength lies. And finally, I hope I've been able to highlight some of the changing manifestations of this disease. I would like to just direct the patients in the audience to patient education websites. They're hot off the press just in the last month. These have been developed by the American Association of Endocrine Surgeons. This is our email address to our website. If you go on that, on the right-hand side, you'll see the patient education site, and it will bring you up to this screen. And you can now see we've developed patient education websites for neuroendocrine diseases, and I would appreciate it if you would take the time and look at them, and any feedback our association would be very pleased to hear. Thank you.